Okay, well, I know that some more folks are likely to be filtering in here in the next couple of minutes, but we do have a pretty packed agenda for this hour, so I want to go ahead and get started. And then, Becca, as more folks are filtering in, if you would please admit them along the way. Becca Thomas is here as our communications director at Groundwork Ohio. She is my colleague as I am the statewide coordinator for the Safe Babies Approach to Infant-Toddler Court Teams in Ohio. My name is Caitlin Feasby. I am, of course, our primary objective for being here today is to learn more about child-parent psychotherapy, or CPP, and the important role that this evidence-based, trauma-informed intervention plays in the success of the Safe Babies approach to infant-toddler court teams in Ohio. In their 2015 study, Lieberman et al. Described CPP as an intervention designed to repair the behavioral and mental health concerns of infants, toddlers, and preschoolers whose most intimate relationships are disrupted by experiences of maltreatment, violence, and other forms of trauma that shatter the child's trust in the safety of attachments. So it's a big topic. It's really exciting that we have the opportunity to bring this training to Ohio. And my co-presenter, Lili Gray, is going to be discussing CPP in greater detail in a few minutes. But I wanted to kick off our meeting today by sharing a brief overview of the Safe Babies approach to infant-toddler court teams so that we can all have a shared baseline understanding around the purpose of the program and the important role that child-parent psychotherapy plays. Really quickly, I want to give a shout out to our National Resource Center, 0 to 3, for supporting the implementation and growth of our Safe Babies court teams across the country and here in Ohio. 0 to 3 pioneered the Safe Babies approach and continue to provide training, resources, responsive policy solutions, and prioritizing their missions that all babies and toddlers have a safe and strong start in life. If you're not familiar with 0 to 3's work, I highly recommend that you scan that QR code or check them out after our presentation. They have a lot of really great resources and information on their website. Here in Ohio, we are really grateful also to our state implementation team that includes these 4 main organizations. Ohio's Infant-Toddler Court Team Expansion Program is being overseen by federal funding from HRSA. And as part of the HRSA grant structure, these 4 organizations you see on your screen are the key players to the oversight of the expansion project. The Educational Service Center of Northeast Ohio is the project director for the federal HRSA grant. Case Western and the Children's Defense Fund of Ohio are really invaluable in their contribution to data collection and continuous quality improvement. And finally, Groundwork Ohio, who I am here to represent today, is a nonpartisan public policy advocacy organization, and we are the home of the statewide coordination of the expansion project. In Ohio, we are considered a state structure as we operate Safe Babies teams in 3 geographically diverse counties across the state. Those include Lucas County and Scioto County. Both of them will be sharing a little bit about their programs later today. And then we also have Cuyahoga County. Each of these communities have very distinct needs and challenges with varying access to resources. The main goal of the Safe Babies approach is to transform the experience of infants and toddlers and their families involved in the court system so that they can be safe, loved, and thrive, and to enable communities to be non-adversarial, racially and culturally equitable, and collaborative as they address the problems that interfere with the health and well-being of children and families. Our vision with this program is to create a future where all families have the capacities, resources, and supports to care for and nurture their children. I want to share just a couple data metrics, a couple data points to kind of ground why this program and this approach is so important in Ohio specifically. Groundwork Ohio developed an Ohio Early Childhood Dashboard and a race and rural equity report that has a lot of interesting data metrics that relate directly to Safe Babies work. I want to highlight a couple here. The first being that in 2019, Ohio ranked 32nd out of all 50 states and DC on child maltreatment. We also ranked 39th on children ages 0 to 5 who are living in poverty. chronic, unrelenting stress in early childhood caused by issues like extreme poverty, repeated abuse, severe maternal depression. These are toxic to the developing brain and can have long-lasting consequences. Many of the infants and children we encounter in the child welfare system experience a series of severe stressors impacting their development. We know this. Thinking about adverse childhood experiences, or ACEs specifically, on a 10-point scale in which exposure to one traumatic event is equivalent to one ACE score, Ohio ranks 46th in the nation for children having clinically significant ACE scores. Really, 1 in 5 Ohio children are exposed to 2 or more ACEs by the age of 5. So this early intervention piece is extremely important. Higher ACE scores translate to increased problem behaviors across the lifespan. So this is where we see multiple generations of these behavioral challenges occurring in our communities. This includes things like excessive alcohol consumption, drug use, violence victimization, or perpetration. We also know that ACEs have physical health implications as well, and a high ACE score is strongly associated with cardiovascular disease, diabetes, cancer, and respiratory and liver diseases. It's also closely associated with poor mental health outcomes, including increased rates of depression, anxiety, and higher risk of suicide. And so really the data is very clear that ACEs and adverse childhood experiences early in life, especially early in that developmental period, ACEs result in lower life satisfaction scores and shorter life expectancies. Evidence-based practices like the Safe Babies approach and child-parent psychotherapy are essential to help prevent ACEs before they begin to impact the child's life and development. A quick overview of the Safe Babies approach and what this really looks like in practice. As I mentioned a moment ago, Safe Babies is an evidence-based approach that's grounded in the science of early brain development. In the first few years of life, more than 1 million new neural connections are formed every second. So our timely and developmentally appropriate approach to working with these young children in child welfare is essential. Early developmental experiences can either lay a strong foundation for a child's life and success, or a weak foundation. A young child's brain development can easily be interrupted by various kinds of trauma, including the trauma of removal, which can be deeply impactful, regardless of whether or not the young child has language skills to tell us how they're feeling. The Safe Babies approach has 5 primary areas of focus that I'll kind of walk you through quickly. The first, as you'll see on the upper right-hand side, is enhanced oversight and collaborative problem solving. We're really looking at a collaborative multidisciplinary emphasis. This is essential to this approach to ensure that there is representation of multiple voices at the table. This approach to problem solving helps to enhance judicial oversight as there are more frequent court hearings, and families are really seen as partners, and interactions with them are guided by respect, kindness, and compassion. Next, expedited, appropriate, effective services. This approach requires proactivity and prioritizes rapid attention to infant and family needs. Safe Babies ensures services for babies and families is timely and comprehensive, with careful attention paid to their lived experiences. And here's this word again, the intergenerational effects of social, racial, and health inequities. Number 3, this is a trauma-responsive form of support. Trauma-informed care is the heartbeat of this approach. And when creating the Safe Babies approach, 0 to 3, our national partner, knew it was essential to prioritize awareness of the ways that trauma impacts how infants and families interact with the child welfare system, while also recognizing the resilience of parents. This focus area requires all working within the Safe Babies approach to take an empathetic and healing approach to working with families and every interaction with them. Interdisciplinary, collaborative, and proactive teamwork, moving here to the left side of the circle now. We're working to ensure that we're practicing from a lens of what is best for the family. This approach takes into account individualized needs of each family and creates individually tailored, creative solutions to minimize or eliminate any structural barriers that they might encounter that could perpetuate discriminatory processes and iniquities while moving through child welfare. And finally, continuous quality improvement through data collection and evaluation practices. The Safe Babies Court Team approach keeps close watch on those trends and uses real-time feedback from data collection to inform practices. And this process is meant to promote big picture reflection rather than instantaneous reactivity. So for example, of course, we're here again to talk about child-parent psychotherapy today. We know that CPP is a strong part of the Safe Babies approach. As kind of outlined in this circle, it is in direct correlation with trauma-responsive support, interdisciplinary, collaborative, and proactive teamwork, and expedited, appropriate, and effective services. The Ohio Safe Babies implementation team is organizing the CPP Learning Collaborative due to the importance of having a strong body of mental health providers trained in infant mental health and child-parent psychotherapy. We also know that we need to be working at the statewide level, and this is where my role as a statewide coordinator comes into play, to be doing additional advocacy to increase billing pathways for infant mental health, for example, as well as access to the DC 0 to 5, the diagnostic manual for infants and toddlers ages 0 to 5 in our state. Lucas County, Ohio, is the Toledo area right on the Michigan border in the northwestern part of the state. Their program called Healthy Baby Court has been long overseen by Judge Denise Navarre-Coven, whose recent retirement has resulted in a transition of the program to leadership and oversight of Magistrate Stoner. And Sarah, if you're here, I'll allow you to kind of come off mute and share a little bit about your program in Lucas County.
Okay, good morning, everyone. Thank you so much, Caitlin. That was a great entrance into this very important town hall meeting that we're having today. I appreciate everyone being here. The work that I plan on just talking about the history of Healthy Baby Court in Lucas County, and then going into the work that we've been doing for the past year since I've been on board, and then just passing the information or the torch or the speaking microphone on to Scioto County. So Lucas County began our Safe Baby Court venture in 2015. Judge Coven went out, and she's always finding very innovative, or was finding always very innovative ways of bringing our community together. And her whole goal is to prevent families from ever touching our system or touching the child welfare system. And so this approach was really fitting. And also recognizing the amount of children, infants and toddlers that are involved in our child welfare system and that are coming to our court as a shelter care hearing where they are placed in out-of-home placement. It's very significant. I'm not going to speak on behalf of the data and how many at this point. But so in 2015, she started building infrastructure for what our community decided to label as Healthy Baby Court, with the goal of not only serving families. So here's the important part that I like to get across to people, is that Healthy Baby Court has 3 different levels of intervention that we are working on, and that our coordinator, Karen Rickettsburg, by the way, I should have said this earlier. She is on a medical leave, but she is our Healthy Baby Court coordinator who works with the families and spearheads a lot of this work. So the work is, I always explain it to people that it's on 3 different levels. So there's a micro level of working with families and helping them, such as Caitlin was talking about, on an individualized level, more intensive court where you come monthly. And in Lucas County, again, Scioto County may do this differently, but so they come monthly to court to meet in front of a magistrate Stoner now, since the retirement of Judge Cubbin. And so we're transitioning our families over to Magistrate Stoner right now. So they meet monthly. And then the micro level also of Karen hosting individualized family support meetings, we call them. So the family and any supports that are involved in that family's life, or we assess the needs, and the caseworker comes, and everyone is very transparent. The community coordinator, Karen, conducts this meeting and is, as we call it, Switzerland. So she is neither there for she's not on either side of the court or child welfare or what have you. She's merely there to help navigate the systemic issues that are occurring and help the family to have the best opportunity as possible to work their case plan with our Lucas County Children's Services. And so in that process, they then all meet and this team comes together, which the micro level of the CPP in this town hall is that we used to have a CPP provider from the Cullen Center that was specifically supporting every family that was involved in Healthy Baby Court. And then around 2001, that we no longer had a provider at the Cullen Center to provide CPP. And so that is dearly missed on our team of supports that each family should be provided. So with that being said, that micro level helps always, the micro, meso, and macro, feeding how to improve our community as a whole, right? And so Karen does intensive work and helps link to supports. And now onto the meso level. That level of work is community level work. And so what we did in 2001 is, when I say we, like me, Karen, Judge, and a lot of people, so not just me, came together. We did a service mapping exercise in Lucas County of services that are out there for our 0 to 3 population, because everything, again, and I do this because Judge Cubbin always did this, is through the lens of the baby and for the lens of the baby and infant involved. And so with the goal of expediting a permanency decision for that baby. So that's very important. Anyways, in that process, the meso level, which is the community organizing and Lucas County and the supports that we have in Lucas County for our 0 to 3 population, so that Karen can then pull them in as needed based on the needs that are explained in our family support meetings, right, or discovered. So we had a huge kickoff in August of 2022, and we had over 100 and I want to say it was like 109 people and over 40 organizations attend that kickoff, where we then were able to develop our 0 to 3 active community team, which is somewhat of a coalition, and it's very focused on our 0 to 3 population in Lucas County. Again, then Karen can pull resources from that network that we have created. That network then created 4 work groups, which they identified the needs, and they identified 4 work groups, one of them being an infant and early childhood mental health work group. And a lot of them are here today. Thank you very much. I'm very excited to see that. And this work group identified their goals of enhancing our workforce for IECMH, and also identified that CPP was something that we would work towards. And I just jump in on the work groups. They do all the work and assist as needed. And I had made a promise that I would try very, very hard to find funding for this CPP training cohort within our community and within our state. And so luckily we did receive that funding to help fund this, to springboard the training cohort for CPP. So we're very excited about that. We also, they've been doing a lot of work, our IECMH work group, on building a sustainable workforce. And so Lindsay Stormer's on here right now. Sorry, I'm just, she and other people in that work group are reaching out to our colleges to help develop early childhood development and therapy, or correct me if I'm wrong, Lindsay, but kind of a what's it called, a certificate of, like, so you studied this in your studies when you were going through early childhood, getting your early childhood degree. So anyways, that's really important. And then we also have another work group. There's 4 work groups, like I said. Another work group that is for plans of safe care, which is really important in this population as well. And CPP is also a proven best practice for our substance exposed babies. So plans of safe care are specific for our mothers that are prenatally utilizing substances, and finding and developing a continuum of care and support for them that is in the community prior to them coming to giving birth and then having their child automatically removed from the hospital, which all of us can't even imagine, what that would be like. And so that is a plan of safe care that is going to be implemented in the community. And so that group is very important, and we envision that CPP will also be provided for those infants and children that are substance exposed as well, which I do have data on that, but I'm not going to tell you all that right now. And then there's 2 other work groups, which is parent voice and education, and data gathering and resource sharing is our other 2. So that's a meso level work, and all of this work is identifying needs and trends and issues that are occurring for the 0 to 3 population, and feeding that to the macro level, which is Caitlin and our state and federal funder, so that we can say this is not just happening in Lucas County, these are our highest needs, but also happening statewide. And so that is pretty much a summary of where we're at right now. We're very excited to provide this opportunity, and we do on the micro level. I know Caitlin was asking like how many people we serve, and people ask how many people we serve, but we are serving right now 9 families. And in over the past, since 2016, when we first started serving families, we've served around 30 families. And so we've had successful outcomes, and I can't tell you all how many successful right now. Sorry. Karen was preparing this presentation and it just kind of came on me, but and so we are also working towards having more families come in. We've taken out exclusionary criteria, and so I'm really excited about that. And with this new CPP cohort, we're hoping that these 9 families will then be able to receive CPP within the organizations that have came forward to say that they would like to train therapists in child-parent psychotherapy. And then the larger picture of CPP for me is that all child welfare children 0 to 5 and their families can be served through CPP, because it is very trauma focused. It's focused on the health and well-being of the parents. And I'll let Lili explain more about that. But ideally, hopefully we can springboard this work, and all of our child welfare, or children and families that have gone through traumatic events, which is a lot, as Caitlin said, will have access to CPP services. There are barriers involved in it, but I won't go into that right now as either, but I'll let everybody else bring those things up, and I'm sure Lili may touch base on that. Is there anything I'm missing, Caitlin?
No, I think that's great. Thank you so much, Sarah, for that overview of the work that you've been doing in Lucas County. Thank you so much for sharing. I
All right.
am gonna pass it now to the Scioto County team who has joined us, and they have a little bit to share about their program as well. Jordan and Kelsey, are you with us?
Yes, we're here. Can you hear us?
Yes.
Yeah, okay. It didn't pop up green like it did for yours, so I wasn't sure. I'm Jordan. I'm the community coordinator for the Safe Baby program here in Scioto County. We started the program in 2020, took about a year of training and things. So about 21 is when we started adding families. This is Kelsey, luckily with the new grant that started last October. Yeah. I was able to get someone part-time to help with the day-to-day of Safe Baby. So that's where she came in. So that has been great. But Sarah did a really good job of explaining kind of what the role of the community coordinator does in their community. And it's very similar here. We facilitate a lot of meetings. We are the middle person. We provide the resources, give them the options that fits best for them, and try to help them navigate that. And she also talked about, the infant early mental health work group they have. We don't have anything like that, unfortunately. So that is, one of the big things that we want to bring here. And with CPP, we think, that will be a great opportunity for our county. Just talking with folks in the community, they didn't even know mental health was an option for infants. So it would be really great to kind of bring that. But I did just want to talk a little bit kind of about where our program currently stands. So from the beginning of 21, we've had 15 families. There's been 25 children that are 3 and under within those families that we have served. There's been older siblings and things, but for data purposes, we don't count those, but we do serve them. And currently we have 9 active families, and there are 13 children or 16 children involved with those families. We actually, probably 3 cases will close before the end of the year. 2 of those families will be reunified with their parents, and 1 family will continue in their kinship care that they've been in since the beginning of removal. So we're looking forward to that, and Kelsey can talk about some of the current positive outcomes that we can have.
So we currently have closed 6 cases. We have a positive outcome is one of the things that Safe Babies is big about trying to do is minimize the time in care. And through what we have seen in our data, our average length of days in care for our families have been about 322 days. So that is less than a year, which is good. We also have had 4 children reunified with their parents at this point, and then the other children, which is about 5, have stayed in kinship care or in whatever care they were in through the system. They've been placed wherever they were in the system at the time. And then Jordan's going to talk a little bit about why we feel like we need CPP for our county, but I think she's going to give one example that we're dealing with right now.
So, I mean, it definitely needs to happen here, only because we don't have anything like that for children or infants and toddlers and their families combined. But we have certain cases that we just look at and we're like, if we had CPP, like they would benefit so much from this. And the closest CPP provider to us is an hour and a half away in Columbus. So it's not, it's not probable that they will ever get those services unless it is brought here. So hopefully, and we do have some clinicians in the county that are super interested in the training. And I think one of the supervisors are on and, observing this and stuff right now. But so we have a family. There are 3 kids. The oldest daughter was 3 when she first started the program, but she is now 4. But she has kind of hysterical fits before, during, and after visits. She's currently in foster care, and so when the foster mom tries to say, like, you'll be seeing your mom today, she acts out at school. She'll have bad behavior. She'll get bad reports. During the visit, she will get so upset she makes herself sick. After visit, she has night terrors. And it's, there's nothing for her currently set up in our county that will help her emotionally through some of those responses she's having. She doesn't know how to cope with it. And the mom doesn't understand. The foster mom doesn't really know how. She's just asking for her to get counseling. And so it's just one of those things that our hands are kind of tied because the services just aren't there for us in the county right now. So we are very hopeful that CPP will be able to step in. And I know it's going to be a little bit before services are possible, but and there's been multiple cases like that where we see these issues and there's just a barrier of no service. And so, we're really hoping CPP will bring, kind of come full circle back into our community, and we'll be able to help those families that are struggling with issues like that. Because we see it a lot. Unfortunately, sometimes children are removed, maybe visits don't start immediately or whatever it may be. And there are, hard issues happening. There's no bonding. And so there's just a lot of emotions going on between the parents and the children, and they just don't know how to mesh. They don't know how to talk through it. They don't know what's going on. They don't understand. So, we're hoping CPP will be able to bring that to our community. So, yeah.
Thank you so much, Kelsey and Jordan. We really appreciate you being here and sharing some of your insights. The remainder of our presentation will be in Lili Gray's hands. So Lili, I'll turn it over to you now. Thanks so much.
Thanks, Caitlin. Thanks, everybody. Hi, thanks for joining us this morning. I'm going to share my screen, okay? I have a little slide deck to share with you just around CPP and to give you an overview. And then I'm going to leave the rest of the time open for questions and your wonderings. Okay. All righty. Okay. So this deck is obviously not a training. We have to give that disclaimer. And it's just meant to be a little introduction to the training. I'm a national trainer. I've been training in CPP since 2004. My connection, I live in Chicago. My connection to Ohio is that I went to Case Western for graduate school, and I lived in Cuyahoga County for a while. I'm from the Northeast, but I lived and loved living in Ohio. And part of our mission when we're identifying where national trainers are going to take over regions is that we have some connection to that region. So I train all of the Midwest, Kentucky, Indiana, Illinois, actually part of Pennsylvania, Western Pennsylvania, part of New York State. That's not the Midwest. I want to give that disclaimer because they would not like to be lumped into that. And all of Ohio. So I'm actually the trainer in Cuyahoga County. And I know the trainers, I know the people who have been trained in Franklin County, in Columbus, where you mentioned. So although I haven't done all the training historically, I'm the person who's there moving forward. I'm also part of the CPP Global Steering Committee. So we're just a group of people. There's only 11 of us who are deciding on the mission of the program and the development and the implementation of the model and where that's going. If you would like more information, I know you can't actually click on this. I think Caitlin has this and can share this PowerPoint with you. And this is just our website. If you go to our website, Child-Parent hover over to providers and training, a lot of the information that I'm sharing with you today is on there, okay? So our 18-month learning collaborative, this is how long it takes to get trained in this model. It takes 18 months. The first is learning session 1, and there's roughly 6 parts because we're doing it on Zoom, right? We're not doing it in person because it's easier to access it, in my view, in these regional, far apart places, rather than all of us coming together in, say, Columbus. If we do it on Zoom, it's more accessible. So we'll do it in probably 6 small parts. And by small, I mean about 4.5, 5 hours each with breaks. And that covers the core didactics. And you can immediately start treating people in CPP, and you should at that time. We immediately start 6 months of consultation calls with me. I'm your trainer and your consultant. We don't have the dates or any of this stuff scheduled yet. After 6 months, we'd have learning session 2, which is, depending on the needs of the group, will be 3 or 4 parts. And this is competency building, case-based, and driven by the learning needs of the groups. And there's 6 more months of consultation calls, and then there's learning session 3. Same as learning session 2, 3 or 4 parts, competency building, case-based, participant-driven, and then there's 6 more months of calls, and then the training ends. Okay, so Caitlin, you mentioned some of this, so I just wanted to review, what is CPP and who does it work with? It gets a little murky for people. We are an evidence-based practice, and an evidence-based practice means that this model has been tested at the highest level of scientific inquiry method, right? That's what randomized control trials mean. That's a double-blind study. And the N, you'll see in the bottom, the N is how many people were involved. So in this first study, there was more than 500 children and mothers involved from a range of socioeconomic status and multicultural samples, and many of these were delivered in Spanish in homes. So these were a group of preschoolers who were exposed to domestic violence or had maltreatment histories, infants from families with a history of maltreatment, anxiously attached infants of Latina immigrant mothers, and toddlers with depressed mothers. That was part of this whole N, this group. And what we found is that there was an improved relational quality of anxiously attached toddler-mother dyads, an improved attachment security, improved cognitive development and parental relationship satisfaction in toddlers with their mothers. There were decreased maladaptive maternal representation and decreased negative self-representation in maltreated preschoolers, improved child behavior problems and trauma-related symptoms, and improved maternal symptoms in preschool mother dyads exposed to DV, and improved attachment security and physiological and I would call it psychobiological relation in maltreated infants. And what we've also found, so we also have had replication, which is really important in our CT studies, this kind of study, that we want somebody else to go repeat it and get the same outcomes, and we've had replication several times. Right? So it's not our opinion that it works. It's been, it's been founded in the science and it's been repeated. And I have all the links here if you're looking for that. It's also on the website that I shared with you in the beginning. CPP is delivered in 3 phases. This is for our clinicians and our administrators to think about. It's 3 phases. We start with the foundational phase, which we call assessment and engagement. And then we move to core intervention, and then closing and termination fidelity guides everything. During foundational assessment and engagement, our job is as providers to develop a collaborative relationship with the caregivers, open a dialogue about risk and protective factors, and talk about the way that treatment may help. During core intervention, we conduct treatment that's guided by case conceptualization, and we call this the triangle that moves us from foundational phase to core intervention, which we co-develop with the caregiver. And the triangle is the story of here's what's happened, here's what you've been through, here's what you've seen, here's what you've experienced, here's what you know, here's the behaviors and the symptoms that you're having, little human, and here's how treatment will help. And then during the termination or recapitulation phase, we review the treatment, how it's gone, we consolidate treatment gains, and address potential future challenges. This is that triangle of explanation that I just created for you. The circles on the outside are how we highlight protective steps that the caregiver has taken, and we hold hope for the family before they can hold hope for themselves that things can get better, because we know that they can. So the experience is the left side, right? This is what you saw, this is what you heard, this is what happened. The behavior and feelings, the example that I think Jordan just gave, right? That this little 3-year-old, I don't know what the experience was, because we didn't hear about that, but we heard, as we often do, these cases, well, this kid is doing fill in the blank, these things. These are, they're falling out, they're screeching, they're non-compliant, they have negative, whatever that means. And now you're doing these things, and that's connected to the experiences that you've had. And this is how treatment will help. So our therapeutic goals in the model is to encourage the child's return to normal development, maintain regular levels of affect arousal, achieve reciprocity in intimate relationships, restore and strengthen relationships between the parent and child, help restore attachment and appropriate affect, and improve cognitive, behavioral, and emotional functioning. The intervention modalities that we use play, physical contact between caregiver and child, language towards developmental goals. We use unstructured developmental guidance. We might model protective behaviors. We often use interpretation, linking the past to the present. We offer emotional support and concrete assistance, case management, and crisis intervention. which many of you probably already do a lot of these things. We talk about fidelity. Whenever you are training or learning an evidence-based practice, you will always be monitoring fidelity, whether it's TFCPT, PCIT, CPP, whatever it is, you're going to be monitoring fidelity, because otherwise you're going to regress to treatment as usual, which may be lovely treatment that you all know how to do, but it will not be this treatment. So monitoring fidelity is the map to make sure you're on the right road. And we talk about 6 strands of fidelity in our model. There's the reflective practice strand, and we have these little icons that cue our providers to thinking about and understanding what these are. Reflective practice fidelity is about me, the provider, and what's happening in my emotional and psychological space and cognitive space. Reflective practice is about me as a provider. Emotional process fidelity is what's happening in the room with my clients, right? What their affective state is, mom, dad, caregivers, child. That's emotional process. Dyadic relational fidelity is thinking about the couple. And this is often what people say is different about CPP for them than their old treatment as usual, is that our intervention is around the dyad, and that is often a new skill set for folks. Trauma framework fidelity is holding that lens of how trauma impacts development and relationships. Content fidelity is the why do we do what we do and when do we do it and how do we conceptualize it. And procedural fidelity is doing the stuff, right? Like sort of the checklist. There's not really a checklist of like, when do we do what and what's different about that? Sorry about that. There's also, this is our little compass of fidelity. This also exists on the website. So some core competencies that providers of psychotherapy need to implement this model would be a knowledge and understanding of adult development, a knowledge and understanding of child development, skills in clinical case management and coordination of care, skills and a knowledge of ethics and reporting procedures and policies in your area, in your jurisdiction, the sociocultural impacts on families, trauma theory, an understanding of attachment theory, an understanding of behavior, that behavior has meaning. The case that Jordan mentioned, like that little child is very upset before and after. She's not being rotten. It's not a failure of socialization. That behavior is communication of a level of distress that we don't understand. How to intervene to support the dyad, and how to use reflective supervision. And this is not an exhaustive list, it's just a summary. To participate in the training in CPP, participating sites should budget time for these activities. Reading the manuals. So the manuals are these 2 manuals. I require both. And you all know this because Caitlin has already communicated this to you. Participation in all Zoom hours of didactic training spread out over the 18 months. Participation in twice monthly, 1 hour at a time case consultation calls. Those are held on Zoom. I provide the Zoom link. I have a business Zoom account that is HIPAA compliant. Presenting your clinical work on at least 2 consultation calls. And the participant site should budget in time for people to not only present, but to complete the write-up, to meet in supervision, to prepare, to edit, to revise. Participation in weekly reflective supervision in the agency, or at a minimum of twice monthly. Completion of clinical measures, fidelity forms, and evaluations of the training. Provision of all CPP services, including clinical set case management and coordination of care. And data collection and learning collaborative metrics. And what to expect if you train with us. You can review all of this at childparentpsychotherapy.com. The first ask is that you complete all the pre-work before we start, and we can talk more about that in Q&A. That you'll attend all the trainings, that you will attend 70% of the calls. Obviously, we know almost nobody can attend 100% of the calls. That'd be great if you do. But 70% is the minimum. that you present at least 2 times on the calls, that you write up your cases and share video of your sessions or very, very detailed process recordings with me prior to the calls and during the calls, that you complete your fidelity tools and share as requested, that you carry cases of 0 to 5-year-olds, that your agency can support you meeting alone with caregivers. That's a requirement, it's not optional. That you can also meet with the child and the parent, and that you attend CPP reflective supervision at least 2 times a month, ideally weekly. Now I will stop talking and open it up for, thanks Caitlin for dropping that in there. Open this up for questions.
Thank you so much, Lili. If anybody has questions for Lili, feel free to come off mute or drop it in the chat. I'll be monitoring the chat so that we can keep the conversation going. Lili, I know that we had at least one question about the recordings that you just mentioned in your last slide there. Can you talk about what the recording entails? I believe I saw in the agency readiness form that it can be on a phone, tablet, computer. Is that right?
Are you asking about process recording or video recording?
Yes,
So
process recording.
those are 2 different things. So video recording is the gold standard, and that is our first expectation, is that we would, if I'm going to present to a trainer, that I would have video recording through a HIPAA compliant setting, right? That I would then share for the purposes of my education, which means you would need a release, right, from the families to do that. That it's only for educational purposes, and it's destroyed. So you're not uploading it to the cloud, you're just holding it, and then you're sharing it only on the call. You're not emailing it, you're not doing, you're not disseminating it in any way. It's for purposes of me learning about your capacity to implement this model. Yeah, however you decide to record that, and different groups have done it differently, it's fine. I think that that's a conversation in your group, in your agencies, and with your teams to think about the best practices on that. But again, it's important that it's not uploaded, is the only thing that I would say about that. Process recording is not mutually exclusive of video recording. Have any of you been asked to process record in your training programs? Oh, okay, so I'm speaking a language we do not share. So process recording it would be, and I have a little template actually from, I want to give credit, it's from Columbia University in New York School of Social Work. For their field placement, they have a wonderful template that they share, and that it's out there on the internet, so I use it because I can't improve on it, of what process recording is and why we do it. And this is a means to, it's a learning tool. It's a learning tool for providers to share their clinical work. We have a strange profession where we do our work with the door closed and nobody can see what we're doing. I don't know how that evolved. Right, even surgeons, medical providers, they practice with others watching. Right, there's this staggered, and we don't do that. So I'm relying on your description of what's happening, and the nature of our ability to describe is that we will edit, even without meaning to. We will edit out things, and that's why video is optimal, because you can't edit it. Right, we're just going to look at it together to see what we see, and we're not going to be able to look at a whole hour of it, but we'll find little ports, and you'll decide what you want help with and what we want to look at. And when you're writing your process recording, how I have done it when I process record, and I still process record, is after I leave the session, aspirationally, I sit down, I do it on Word, and I type, because I type faster than I handwrite, and I try to get everything down that happened in the session. And then I go back and think about it. Oh, wait, there was something else. And I put that in. And no, there's something else. I put that in. And then I go back in and I think about, how do I feel? Like, what am I feeling about this? What am I reflecting about this? And I put all that in. And what I like about Word is, you can cut and paste things. If I get it out of order, I can go, that didn't happen then, that happened here, right? And get it all out there. And then I send it to my consultant. De-identified, obviously. I send it to my consultant, and then they read it in preparation for our consultation to talk and to think about that case, right? So it's a way for us to, I'm trying to think of the word that would, to take away the curtain from what we're doing, right? That to really make it very transparent what we're doing in our work as a means, as a learning contract. Does it make people uncomfortable? You betcha. That's why I said that, you know, it is not normed in our profession anymore to share transparently what we're doing in session. And our position is that's the only way to learn and to uptake a new model for any model. Other models require you to provide video recordings of your sessions, right? Other models with fidelity. So it's not different in that respect, but that would be an option if video recording isn't available.
Thank you, Lili.
Of course.
I got a direct message in the chat that I want to address that's asking the price of the training, and I apologize, I did not mention this earlier. But as Sarah kind of referenced, she was looking for funding to bring this CPP Learning Collaborative. So a big part of that has been this additional funding that we've gotten from HRSA, from our federal HRSA grant. We have a couple of folks on our call today that work for the Educational Service Center of Northeast Ohio that are really helping to budget out those funds and put them to use. So this training will be covered as far as Lili's time and the calls with Lili, as well as the 2 books that Lili mentioned. All of those will be covered by the additional funds from the federal HRSA grant. If you have additional questions about that, of course, you're welcome to bring it up in our last several minutes here today. Otherwise, you can reach out to me directly if you have questions about the billing or pricing or anything like that, and I'd be happy to talk with you more in depth about that. Lili, another thing I was hoping that maybe we could touch on is the agency readiness assessment. If you wouldn't mind sharing maybe the importance of filling that out and kind of the process for getting this learning collaborative started.
Yeah, thank you. I had shared with Sarah and Caitlin and Lindsay, maybe last month, was it? Or even August, an agency readiness tool that we have in CPP that I think we've shared with all of you. I only got one back. We are asking that you complete that before you're invited to present, to have applications, to have a sense of just where your agency is in terms of, say, those core competencies. Right? So if infant mental health is brand new, that would be important for me to know. And it might actually, and we've talked about this is not a surprise to us, it might require that we add some more pre-work, which would be didactic with me or with another trainer around infant mental health, the impact of trauma on young children, or reflective supervision and what it is. If you don't have a practice of reflective supervision in your agency, that would be something we'd want to build aspirationally before we started. And we don't expect you to do that on your own. We would want to support that. So if you don't have that link, I think Caitlin has it and could probably resend it to you. And then that just populates on my end. It populates into it. We run the whole training from Google Drive. So anything I send you will then populate into a spreadsheet into your Safe Baby Court Team Ohio folder that lives in my Google Drive and Caitlin has access to because we shared it with her. So we can just see your responses. For the most part, and sometimes you're asked to put your name, but once we get to the next level, past agency readiness will be an application in a Google Doc that I will send through Caitlin, she'll send to you. And every provider who'll go through the training needs to complete that. So if Caitlin's going to be, I know she's not, but if Caitlin's going to be a provider, if Sarah's going to be a provider, each of them needs to fill that out. It is required that when you send teams that you have to have a supervisor go through the training with them, and the supervisor must also carry cases. So when you're thinking about who to send, that's a consideration because many of us as supervisors are not case carrying, right? We generally have either a very small caseload or we've stopped carrying cases. So it's something to think about. Administrators are invited to learning session 1, but not to learning session 2 and 3. We really would like you all administrators to become cheerleaders for the model aspirationally and to hold that in your agencies. Thanks, Caitlin, just added that.
Absolutely,
Yeah.
Thank you, Lili.
And we haven't shared the application for each clinician yet because we were waiting for all the agency readiness surveys to get returned.
Thank you. And as you all know, this is being recorded, so I plan to share this recording you can reference back to in the future or share it. And then I will also provide that agency readiness survey link again after our meeting is completed today. I did get another direct message in the chat asking for me to mention the start date. So we originally had identified a start date that was in November. However, with the coordination of getting those 2 books out to everyone with enough time for each clinician and supervisor to consume those books and show up to the learning collaborative ready to learn, as well as the the readiness assessments and the applications, it was identified that we needed a little bit more cushion room to really get this up and running. And so Lili Gray, the Educational Service Center, and myself, we're in communication. We're continuing to move forward with all of the stuff in the background to solidify new dates that we anticipate will be available in, or that will be beginning in early 2024. And as soon as I have that information, I'll absolutely be passing it on to each of you. I know we have a few minutes left. Are there any questions anybody has that we haven't touched on yet, or anything that's not clear that you would like us to expand on while we have this time together?
Since nobody's asking questions, I just have a few things that were on my mind. The sustainability of providing CPP services, because I know people in leadership positions are like, okay, how are we going to sustain this? How do we bill? How do we, make sure that, so that we can afford to send these people and that there's a return on providing CPP within our organization. And so I know that this is a commitment, but we are working, and I'm saying we because at that macro level that is needed, the advocacy is needed, and we are hoping that training and providing this will help to produce positive outcomes, not only within Healthy Baby Corps, but you can also serve the 0 to 5 population. There are some, I'll just say, some biases that people have in diagnosing babies and providing, therapy for babies. And it's really a family therapy. And so there are, in our managed care networks, we're going to have to do some advocacy. We do have our Lucas County Mental Health and Recovery Services Board on board with this. Also in Cuyahoga County, they have been providing this, providing these services, and Lili has also done the training for the cohort in Cuyahoga County. And so we have our IECMH work group that is working diligently on this work, and Caitlin and a bunch of other people at the statewide level, the Aim High Ohio people are working very diligently on having CPP provided as well. So I just wanted to, I have no specific way of saying, yes, we can bill and we can do this as of yet. But we do have like POS funding, and we do have other ways that we can try to collectively figure out the best way to bill. And PCIT is being billed for as well, but that's that does not serve the 3 and under, or maybe 2 and under population. And so we're hoping to really learn and expand and bring Ohio up to the infant-toddler infant mental health standards that multiple other states in our country are providing. If that's helpful.
Thank you, Sarah. Yeah, we know that step 1 is really having a strong body of clinicians that can provide this work and improve the experiences of infants and young children in our communities, where we know that there is so much need. And simultaneously, we know that there is additional advocacy opportunities to build a really strong foundation to make sure that this can continue long into the future. And so I see in the chat, Lindsay shared, we also have been tracking Medicaid codes being used for CPP services in the state. So these conversations are happening. We are having these conversations and moving this work forward. And I see that a couple of folks are dropping off. I know that we're just a minute over the hour, so I will bring us to a close, but really appreciate everyone's time. Thank you for being here, and I'll be following up with an email. Again, this recording, you're welcome to share it with anyone who wasn't able to join today that you feel may benefit from the information. If you have additional questions, you're welcome to reach out to me directly, and I will drop my email in the chat. Thank you so much.
Thanks, Caitlin.